When I'm asked to talk about pearls and pitfalls in multifocal practice, when I'm in front of a tech-savvy crowd like you, who just at the press of a button on your mobile can get several of those lists, with dropping down list with, what are the pearls and what are the pitfalls. So I was just wondering, what is it that I should be talking when such a lively discussion has covered most of it? I have done multifocals from the 3M PMMA multifocal to array to the present day symphony. And all of them, and some of them to my own relatives. And they all have done well. There were some who needed their lenses to be taken out, but they had very distinct reason. Either they were medically unfit and we had unnecessarily put without doing proper examination. Start. Or some of them were the ones whom you had promised a rose garden with a moon shining all the time, and they were just fixed into that fantasy picture and they were not getting it today. Barring that, over the years I have realized very often we talk about quality of vision, contrast, and so many other fancy things. But believe me, my friends, now when I'm talking, it is after 35 years of experience. All this is either in the lab or in the clinic when you're examining a patient. Once you're out on the street, the reality is different. And all that hype about 6.6 N6 is industry driven. See, we are in the business of selling visual happiness. And in your day-to-day life, there are several of them. I always, I would touch upon certain cases. You can, these are naive ones, but while going home, just think over it. All our aphakic patients with those thick glasses, were they depressed ones? Did they have suicidal tendency because they couldn't see well? Look at those RK patients. We did several of them, and several of them were done in different places. And they all were happy. And today when they come with hyperopic shifts and lens opacities, and when you ask them, but how did you do after the surgery? They said, we were good, we didn't have to wear glasses. And then you examine him and you find all sorts of corneal problems. You see excessive amount of higher order aberrations, coma and trefoil, and you take out all the printouts and show them, and now his depression starts. And then he's, yes, doctor, I did have this, I did have that. All this. Now just imagine, very often a patient comes to you. He's undergone surgery in one eye. You look at that eye, it's horribly done. And now you want to do the other eye, and you do a perfect case. When the patient comes post-op, he says, but doctor, with this eye, I can see everything. See, to him, if he can't read well, or if he doesn't have good reading vision, he's not happy. So what happens is we don't really check into what exactly is a patient's need, because that decides, what kind of a vision you're going to give him. See, when you do have, when you do multifocal, you do have unhappy patients. And you have unhappy patients because they are medically unfit. Now, I have removed over the years several of those lenses But there were definite reasons. Like there was a multifocal in a patient, who had Stegarts. There was a patient in whom I had to remove it for, because that lens was grossly decentered. And then the second set of patients were those, for them, there was no realistic expectation. And they were promised this and that and that, and they just stuck on that. In my practice, I have seen when I do a multifocal, first post-op day, he's very happy till he walks into my clinic. Then when he sits for an examination, a smart opto checks him and then tells him that, look, your vision is little short of 6.6 and you don't have N6, it's probably N8. And then his problems start. This 6.6, N6 business is good to discuss, good to do a research, but to a patient, it makes no sense, because what he wants and what you're going to give him is, happiness and satisfaction after lenses. So for me, in my practice, I tell my patients, all the lenses will give you glare and halos. Some lenses will give you minimum, some lenses will give you more. All patients will require glasses. For some, the need for glasses is all the time. But for some, it could be absolutely minimum amount of time. But all of you will. But what I promise you is, today your vision is affected because of this, this, this. After the surgery, I promise you'll have a clear vision. But if you need to wear glasses, it's absolutely okay. I tell you one thing, in the year, long back, maybe in 95, I was doing live surgery in AIOS in Delhi, and a surgeon was operating next to me, was a Japanese. And that time I heard that this guy had done around 30,000 operations before he was there. He didn't talk a word with the patient. Just before, he just took a bottle out of his pocket and just put some drops. There was no anesthesia. That was probably some kind of a local anesthetic he had in his pocket. He just sat, even before I knew anything, without talking a word with the assistant, without talking a word with the patient, forgetting what language he speaks, and his surgery was over. So that means it was all in the head. Remember your days when you started your topical, hesitating, should I do, should I not, should I do, should I not? And today, every patient, when you do topical, you really wonder, are the local anesthetic better than in those days? How is it that patient accepts it? He accepts it because you are beaming with confidence. It's going to work. See, remember one thing. It's the body language, finally. If I'm offering a multifocal to a patient, and if I'm talking about these glare and halos, and if I'm not confident enough about the technique and the results, then that patient sitting in front of me is going to pick it quickly. So that means you have to have, but then you can't feign confidence all the time. You have to believe in it and you have to get it. So that means a bit of experience will definitely make you much better equipped to put a multifocal. I don't think, we are running behind the schedule. There are a lot of things, but they're all common. But I would like to leave now, with permission from Arup. Everyone can do multifocal practice. I was talking to Dr. Noor. He's a very high volume refractive surgeon. And he said, I don't do much of refractive practice, meaning multifocal practice. But I don't do much of cataracts, but I do it only for patients asking for refractive, results, like all high myopes, or anyone who wants to get rid of his glasses. He doesn't have cataract. And my percentage is around 65 to 70%. Now 70% of his practice in Europe, where patients definitely want high quality vision, his is multifocal practice. Why it is multifocal practice? Because he's confident enough to back it with touch-ups. So if you want to have a multifocal practice, you should have an access to touch-ups, because no matter how accurate you are in checking your biometry, once in a while you are bound to get some refractive surprise. And a small refractive surprise can be taken care if you have counseled him that he may need glasses for some time, and that some time is this. If that be so, I think all of us, now just imagine, we talk of the eye dominance. It's all, sorry for the word, it's all humbug. Now I have done cases where in the right eye I did array lens. He comes 10 years later, 8 years later, I'm asking him, what happened to you? No, I was managing well, I didn't come. There are several of those young teenagers, traumatic cataract, you put multifocal, they do well. Imagine an ophthalmologist in those days, I forgot his name, he was the first guy to get array put in his eye, and then there's a whole history of how we went through this, that, he was doing well. So that means all this drama is in the first 2-3 months of your putting a lens, because one thing that we underestimate is the neural adaptation. The human mind is so fantastic that anything and everything it will take care. So have total faith on neural adaptation, your confidence and your chair time before putting a lens, and you can put multifocal any kind. Now just imagine if refractive multifocals are not as good as diffractive, then why would a reputed company like Rayner still continue to produce refractive sulcoflex lenses and primary lenses and still continue to have market? That means there is a market. That means any lens can be put. Well, I'm little different from what is being discussed, but that's my experience, and that's what I thought I'll share more than taking you through all the presentation. Thank you so much.